Hi everybody, and thank you for all your questions on the polyvagal approach and movement strategies for pelvic pain. And thanks as well for all the great questions that you sent in. I'm looking forward to taking a jump in and discussing them. So we'll start at the beginning and we'll work our way through. Okay, you mentioned the association of back pain and pelvic floor dysfunction. Do you find it hard for patients to accept or acknowledge this? No. Initially, maybe yes, but no when you explain things to them and you tell them about the research and how back pain is different for women than it is for men. And I always find that having a good selection of anatomy models is really helpful. So what I will do is, I'll bring something like this out and I'll get them to put one hand on the lower back and one hand on the tummy, and we talk about all the different structures that are between the two hands, the bladder and the uterus and the rectum and the coccyx particularly. And once you actually start that conversation, I find that people are so relieved that there could be a different driver for their pain, that they're usually quite open to trying a few different things. I think the other thing to remember maybe would be as well that as we try to move away from a purely biomedical and biomechanical focus with back pain particularly, it's important to also point out the different lifestyle inputs on both pelvic floor muscle dysfunction and back pain. So obviously constipation is one of the things that I talk about a lot, but there's some really great research out there talking about the issues with sleep. And disrupted sleep can increase musculoskeletal pain by about 25%. So that's huge. So we talk about sleep, we talk about stress, and then of course the factors that are specific for women with back pain, which would be constipation, bladder control, and breathing. And generally I find that once you start educating people about their own bodies, they're actually quite receptive to that whole concept. What is next in the questions? Given that for clients these might seem like two very separate entities, is it something you feel all MSK physios should be screening for? Yes. But having said that, I started out in sports injuries 150 years ago, and you do the screening questions like any issues with your bowel or your bladder, and you'd be like, please say no, please say no, please say no, so we never have to talk about this again. What we have to do is just really normalize those questions, particularly after any trauma where we might be screening for called equina issues. So to really normalize a conversation about bladder function, about bowel function, about sexual function, and then to be able to take it to the next level. And I think it's absolutely imperative that all physios, MSK, neuro, as well as pelvic health physios, talk about things like that. Okay, let's see what else we have here. Tips to engage clients in exercise. For patients who are really uncoordinated or have bad body awareness, where would you start? I'd always start with the breath. I think it's a really good place to start because you're doing it anyway about 20,000 times a day. And just by changing the breath, and maybe even trying strategies like putting the hands on the tummy, sitting on a firm chair, doing a little wiggle side to side so you can feel the ischial tuberosities, practicing different techniques, either like alternate nostril breathing, where you're closing one nostril, you inhale, close, open, exhale, inhale, close, open, exhale. And 5 minutes of that a day has been shown to alter autonomic activity in your inner heart, even for non-yoga practitioners. So breathing can have really profound effects. There's another study showing that deep, slow breathing can really modulate pain output from the brain. So it's really interesting because it can be both a top-down and a bottom-up moderator and modulator of pain output from the brain. So I'd start with breathing. I'd start with walking. I think that's a great activity as well, especially as the weather starts to improve a little bit. And then just simple things like rolling out the feet can be a great way to start, because another thing that I'm very fond of saying as well is that about a quarter of the bones in our body are in our feet. So if your feet aren't happy, nothing else is going to be happy. And doing something like rolling out the feet, like we did in the video, can be really helpful for getting people out of their heads and back into their body again. And so we talked about polyvagal theory in the movement video. And what we want to remember about that is that 80% of vagal fibers are going from the body to the brain. So I think what we're starting to realize now is that you can't really think yourself out of pain, or you can't really think yourself out of stress to a degree as well. Movement really is medicinal when you have chronic pain, and to get someone's feet nice and mobile can be a really lovely way to get them literally grounded and feeling their bodies again. And that, coupled with the breathing and some walking, again, lovely place to start if they're not inclined towards yoga or Pilates or different things like that. The other thing to remember when you're using the balls, whether you're using them on the feet or on the neck or the shoulders or the lower back, is that much like foam rolling, we're not trying to break up adhesions or lengthen fascia. We're having a conversation with the nervous system. So it's the descending noxious inhibitory system that we're working with. So it's quite an intense sensation, you know, when you're rolling out your feet or your back or your shoulders. And it's really useful because it's teaching your brain that intense sensations from the body do not equal damage or threat. And so you can relax into it and you can move through it. So I think that's the true value of something like either the balls or, like I said, a little bit of foam rolling, is just to really tap into that diffuse noxious inhibitory system that we have. Brains are brilliant. Now, what else do we have here? Would you recommend abdominal massage every day? How deep and how accurate does the technique need to be to see benefits? So to start with the second half of that, how accurate does it need to be? I think it needs to be reasonably accurate, and that you are kind of following the pathway of the ascending, the transverse, and the descending colon. But you do want to remember that what we're trying to do is, again, stimulate a parasympathetic response, so messages from the vagus going back up. And we're really trying to stimulate that rather than physically propel fecal matter through the bowel. So it shouldn't be uncomfortable. It should be very calming and soothing. And that's why using something like the oil to trigger that olfactory reflex as well. Your brain loves habit. It loves knowing what's going to happen next, because it takes so much less energy than for it to figure out a new way of doing things. So if you do it every day for 3 weeks, you know, your bowel is like a large ocean liner. It takes a while for it to change direction. It doesn't like change. So you want to go slow and steady with it for about 2 or 3 weeks. And then generally what might happen is that you get a whiff of the lavender oil, for example, in the morning, and your brain is like, oh yeah, I know what's going to happen next. We're going to get ready to have a bowel movement. And so all those nerves that are firing and wiring together kick into action, hopefully, and we start having a happier, healthier, more regular bowel movements. Let's see, what is next? So yeah, I would do it every day as well, because again, habit and just laying down those neurotags for your brain as well. What percentage of patients do you think clinically have constipation associated with their pain? I would say a lot. You'd be amazed what people think is normal. And I know the Rome 4 criteria say that, well, what's normal? Anything from 3 bowel movements a day to 3 bowel movements a week. But if you're eating 3 times a day and you're not getting rid of what you don't need, that's a lot of stagnation. It is particularly worrying from a female hormonal balance point of view, because if you're constipated, you're actually recirculating those conjugated estrogens back into the system again. So that's not great for issues with endometriosis, perimenopause, PMS, fibroids, all of which, you know, are driven by excess estrogen in the system. But certainly if you're constipated and you're backed up, like we've all been there, and it's really uncomfortable and you're disinclined to move, and your lymphatic system can get a little bit stuck as well. So not great if you're on the path recovering from breast cancer or gynae cancer. So I would say a significant amount of people have constipation. So like I like to bring out, let me just take the pens out of it. I like to bring out, you know, just easy ways to start talking about Bristol stool charts, you know, just to keep it casual, but keep it informative. And again, putting people back into their driver. So it's all about promoting self-efficacy. And I would get people to look in the toilet bowl every day after they've had a bowel movement as well, because, you know, blood in the stool is a big red flag. It could be hemorrhoids, it could be fissures, but it could also be colorectal cancer, you know. So looking in the stool and getting people to report back to, you know, was it that lovely, nice, aspirational type 4, smooth and soft like a sausage or a snake? Was there blood in the stool? Are you more towards the constipation end or more towards the diarrhea end? And then you can start teasing things out and seeing what's actually going on with that. Okay, what else have we got? Do you get patients to stop all other forms of exercise while they engage in this program? No. Let me see. Is there any particular type of exercise you would definitely avoid or recommend? Walking's a super exercise. Anything that they enjoy doing, and they're more likely to do consistently. So absolutely, as long as you're enjoying it and it's not hurting you, have at it. Do you find in general an exercise-based approach is more effective standalone than hands-on treatment, or would you aim for a combination of both? If I had to choose, I would go with exercise and kind of, you know, integrating mind body, because I think that really promotes self-efficacy. I think if we are too heavily focused on hands-on therapy, a very biomedical, very biomechanical approach, it promotes dependence. And it promotes the notion that the issue's in the tissues. And we know that pain is an output of the brain. There can still be issues in the tissues, but our manual therapy skills are really interacting with the nervous system and the brain, rather than breaking down adhesions or stretching fascia or things like that. So I think if I had to choose, I would choose movement. But if you can do both, I would view manual therapy as the gateway towards calming down the nervous system and reintroducing movement. All of the literature around back and pelvic pain increasingly is that self-efficacy, stress management, and getting all the other lifestyle factors like sleep and nutrition and bowel health and the microbiome, all of those things play into it. But at the end of the day, we want to encourage self-efficacy and agency over your own outcomes. And I just remember a quote from, I want to say Pete Moore, when he's talking, he's a patient advocate for people with chronic pain, persistent pain. And he said, you know, when you were learning to drive, which seat were you in? Like, you might start out in the passenger seat while you're watching the other person doing the brakes and the accelerators and the mirrors. But ultimately, if you're going to learn to drive, you have to get into the driver's seat. And I think that really changed my perspective. And I think movement really is, it's an empowering way to start taking charge of your own health again. Let's see. I think that physio for endo is still largely underutilized. Where do you get the majority of referrals? How can we continue to promote our role in management of chronic pelvic pain in this patient population? I would say reach out to the endo community and use your social media to talk about what it is that you can do. The gold standard for management of endometriosis is prehab to calm everything down, laparoscopic excision with clear margins, and then rehab afterwards, not just pelvic rehab, but whole person rehab. But if people don't know that's what we do, I think we're too good of a secret, to be honest, for our own good sometimes. So spreading the word about what it is that we can do, about the evidence that supports what it is that we can do to help women with endometriosis. I've spoken a couple of times at the Endometriosis Ireland annual meeting. I'm going to be speaking at the Endo Summit in the States next month. Get yourself out there, start the conversation going, reach out to surgeons who are doing endometriosis excision, and just let them know that you're out there and what you have to offer. I think that's really part of the solution. But then reaching out to the chronic pelvic pain support groups, offering to go do a talk for them on what it is that physio can do for them. The next question on the list underneath that was would you use these techniques with endometriosis? And I would say absolutely. Bowel health is super important for women with endo because, first of all, it's how we excrete excess estrogen. But oftentimes women with endo have what they call endo belly, and they're often misdiagnosed with IBS before they get the accurate diagnosis of endo. I'm cautious about manual therapy and women with endometriosis, people with endometriosis, because I think if you're doing internal work, particularly, I'd be super hesitant about doing internal work on people with endometriosis, because it's very easy to flare them and not be able to settle them down again. So movement is great because, again, self-efficacy, working with the brain and the nervous system. There can be a bit of kinesiophobia with people with endometriosis. So start low and go slow would be the motto here. But ultimately, what you want to think about is opening the front line, strengthening the back line of the body. Too often, women with endo either have ablation, which is literally just burning off the surface of the endometriosis, which is going to get you maybe 2 or 3 months relief, and then it's going to come back again, or a hysterectomy, which of course leads to a whole other raft of problems in terms of bone health and heart health and brain health. And I think those are very underserved women as well. So with endometriosis, calming down the nervous system, working on any autoimmune issues that are there, really looking at nutrition, sleep, stress management, but movement is definitely a cornerstone of both prehab and rehab. Okay. For the tummy massage, is lavender in particular good for this, or could you use any essential oil? I personally like lavender because it's safe, it's sedative, it's soothing. There's a little bit of research behind it. Lots of essential oils are too strong to put neat onto your skin. So with any oil that you're using, even lavender, like always do a little patch test on your forearm first and see how you respond to it. But lavender is probably one of the few essential oils that's generally safe to use neat, undiluted. There are other oils out there as well. I've used ginger essential oil, but diluted in a base, because ginger essential oil would have particular affinity with the digestive system. But do a patch test first to make sure that it's tolerated well. Do you ever run pelvic pain classes? And if so, how do you find they work? What considerations would you have for running one online? I have, and they've gone really well. I've done a couple of like 1-day in-person classes at a patient level, and I think running them online would run the same in terms of just breaking up that 1 day into 6 bite-sized pieces. Maybe I get out the flip chart, we talk about the neuroscience of chronic pelvic pain. What does the evidence tell us? And the evidence supports movement, particularly yoga. It supports mindfulness. It supports sleep hygiene. It does support pelvic floor manual therapy. But if you're just doing manual therapy without a follow-up exercise strategy, you're doing your patients a disservice, because it's only going to be short-term or temporary. So breaking it down into bite-sized doable pieces if you're doing it online. Generally, I find that doing videos online, about a half an hour is the max you can retain attention for. And then maybe setting up a Facebook support group or a WhatsApp group, something like that, to keep a little bit of momentum going as well. But if they're focused around movement, so generally movement for maybe 25 minutes and then 5 to 10 minutes of a chat about a specific topic, that might be another option for doing it as well. But I've done them for back pain, I've done them for pelvic pain, and they've gone well. People are really receptive. You made reference to a couple of authors who have researched this idea of polyvagal approach. So, would you mind sending me the references? I'm going to get you to harness the mighty power of Google. Stephen Porges, P-O-R-G-E-S, is really the godfather of polyvagal theory. So he's written tons of books. They can be quite dense. Deb Dana, D-A-N-A, has written some great books about this as well. I find what works really well in conjunction with this polyvagal approach is compassion, and particularly self-compassion, which is really, it can be quite challenging for a lot of people with chronic pelvic pain, because there can be a lot of anger and a sense of betrayal about their own bodies, and why can't I just be normal like everybody else? So Kristen Neff, N-E-F-F, has written some great books on the practice of self-compassion as well. So those are where I'd start with. My question is, how do you assess or target the appropriate areas of the body in a half to 1 hour treatment session? Are there any unique assessment tools you would use to direct treatment, or based on a thorough whole body assessment, you address the most dysfunctional area of the body first? I would ask the person in front of me what their priority is, what's their biggest problem. And then I would look at bowel health. I would look at movement strategies. I would look at sleep. And I would see what resonates with them first, because what resonates with them means they're probably going to be a bit more consistent with it. What have they got the greatest buy-in from? And I'm currently in the middle of doing a postgrad on health coaching. And it's so challenging for a physio to do this, because we're used to coming in like mechanics and fixing people. And the whole premise of health coaching is that the client has all the answers and you have to help tease it out and then support them. So you ask them, you know, what would successful treatment outcomes look like for you? And they can describe what a good outcome would look like. And then almost like you have to reverse engineer it. So in order to get from here to there, this is what we need to focus on. Let's start there. But generally the research shows that changing exercise habits has a domino effect on other health-related quality of life issues. So if you can get somebody exercising more consistently, they are more likely to make better choices in other areas of their lives as well. So getting the basics right, first of all, like just getting a gentle movement practice in and teaching them ways to start calming down their nervous system themselves, so they're not dependent on you. And then you work with what evolves as time goes on. So there isn't really a cookie cutter response to that. You find out what's important to them and start there, and hopefully that's going to work out. If you have any advice how to help someone with pelvic adhesions from surgery, endometriosis, and another with persistent left-sided lower rib pain and tightness who also suffers from constipation and anterior hip pain, get the constipation sorted first. So all the things that we know work well for constipation. Movement. Manual therapy does not break up adhesions. What manual therapy will do for adhesions is it will calm down the nervous system. It helps put the person back into their body again, because sometimes somebody who's had endometriosis or who's had a lot of surgery and is still suffering the after effects of pain from that surgery, and there can be a lot of dissociation as well as a lot of tension. So teaching them how to do self-myofascial release, self-massage, and getting, again, out of the head, back into the body again, using the breath, using movement. For constipation, are they eating well? Are they digesting well? Have they got good pelvic floor movement? How's their coccyx? The coccyx is such an underrated part of the pelvic girdle. There's some lovely research that just came out last year from Ruth Marr's group in the US, showing that external palpation of the coccyx can really give us a good indication of what's happening with the female pelvic floor in terms of pelvic floor muscles contracting and relaxing. So teaching somebody how to do that themselves, palpating your own coccyx externally, and see what happens when you're breathing, when you're closing and lifting. Can you feel the coccyx moving up and forwards? Can you feel the coccyx moving back down when you let go of the pelvic floor muscles? And again, like that's biofeedback, isn't it? Because all biofeedback means is that you're bringing awareness to a process that's normally unconscious. So instead of using machines with beeping noises and flashing lights, you use these biofeedback devices because they are in direct communication with the person's own brain. So again, you're empowering self-efficacy, all that stuff that I talked about. So movement would have been the short answer to that question. What should you do? Get them moving. Can we prescribe those exercises with the leg drawing the alphabet if the patient is pregnant in order to help the lymphatic system? Yes, unless they're having any symptoms of vena cava occlusion, but your body will tell you if you start to feel a little bit lightheaded or a little bit ick, roll over onto your side. But generally, yeah, you can go into like a semi-reclined position and you can try that. Would you recommend any other exercises for the lower limb to improve the lymphatic system in a pregnant patient with PGP and swollen legs? If at all possible, get into the swimming pool, because the hydrostatic pressure from the water it's like a giant compression stocking basically for the lymphatic system. Failing that, good pair of support tights is great as well. Movement. Your lymphatic system doesn't have that sort of contractile ability that the arteries have. So it's dependent on both muscle pumps, so active muscle pumps, like we would do when we're exercising, and then just random involuntary contractions of the lymphangian segments as well. So movement is great, getting off your feet. Your lymphatic system hates motionless standing and motionless sitting, particularly if you're sitting with your hips lower than your knees, because it kind of crimps off those inguinal vessels at the top of the hips. So movement is great. If you're constipated and you've got a baby as a passenger here as well, that is squishing your lymphatic system. So what are they doing to counteract the constipation? Is it because of their iron supplements? Ask if they can switch over to something like Spa Tone, which seems to be less constipating than the standard iron supplements. Are they eating plenty of fruit and vegetables as well? Are they hydrating enough? Because oftentimes people with leg swelling restrict their fluid intake because they think that's what's driving the swelling, and of course that only makes it worse again. So make sure they're hydrating properly as well. Pelvic floor muscle activation. The pelvic floor muscles are like a little sump pump in conjunction with the diaphragm for your central lymphatic system. And your deep breathing exercises, good for calming down the pelvic girdle pain. But also when we do that deep breathing with the pelvic floor particularly, it creates a pressure differential between the thoracic cavity and the abdominal cavity. So it acts like a big giant vacuum to help move everything back into the system again. Mobilize the feet so it's more comfortable for them to walk. So again, get your yoga tune-up balls or something like that. Movement, pain-free movement of both body and bowels would be where I would go first. But if I can get into a swimming pool, it's brilliant for stuff like that. Does Michelle have a reading list or a book reference to support this area of women's health? There's hundreds of references in the pelvic pain course. I can't give them all to you right here, right now, or I'll be here for hours. You know, there's tons of research out there. If you look on PubMed, if you go to Google Scholar, the research is there, you know, and it's really been exploding over the past couple of years as conservative management strategies for pelvic pain has been growing, because the standard treatments medically and surgically have not worked. They're not giving good results. And we see that with back pain generally as well. So there's a huge opportunity for us as physios, as movement prescription specialists as well. You know, maybe collaborate with a movement specialist if you're not confident, if you haven't got that in your toolbox yet. Can you connect with a Fit Pro or a yoga teacher or a Pilates teacher and maybe do a workshop together, or maybe just find out if you're simpatico in your teaching and your approach to managing pain? But movement really is medicine. You know, I don't have the list of references from the course to hand. They are all in there. Is this program effective for interstitial cystitis or bladder pain? Yeah, it is, because, you know, one of the main drivers, you know, interstitial cystitis is neither interstitial nor is it cystitis really. So for most women with bladder pain, they don't have the typical Hunner's ulcers, but what they do have is overactivity in their pelvic floor muscles. They usually have some sort of bowel dysfunction, high stress levels, poor sleep, overactivity in the muscles in around the pelvic girdle, and brains that are hypersensitive to bladder stretch. So yes, movement is key. There are certain muscles that do seem to typically develop myofascial dysfunction in bladder pain syndrome. But generally, as I said, manual therapy is to calm the nervous system down. Then the job is actually to get women moving again. But we do know that for any bladder dysfunction, bowel dysfunction will turn the volume up on that, particularly constipation. And yes, it is still my favorite thing to talk about. I hope that was helpful for you. Great questions. And if you have any more, you know, you can tag me on social media. If you haven't already, if you're a physio, come and join the Global Pelvic Physio group. And hopefully I will see you in the pelvic pain rehab course at some point if you want to develop a bit of just maybe a slightly more expanded toolbox moving forward. But happy to answer questions and to keep the conversation going. So until next time, thanks for watching and bye for now.